I think I will, it's the time, oh, right on time. I'll stop for questions.
Do you have the information on the clinical trial that's taking place here of nivolumab plus Sutent?
Yeah, we had the study open, unfortunately, for logistics reasons. That was early, sorry, I have to answer. So someone was asking about a specific trial about nivolumab plus sunitinib. We were on the dock. We'd done all the, and we were participating actively. That was a very early stage study, so very small numbers of patients, about 15 centers across North America participating. And unfortunately, for some logistics reasons, we had to actually close that one down. We're looking to there's another study that we've been invited, very similar, and we're in the process of trying to open that study up. So we have a replacement study for that, but in the short term, that study has closed at our center. It was very difficult to get patients on it for various different reasons, and so there's limited. While we love having trials, you can't have trials open that we can't get patients onto because it takes up resources. So we want to make sure we have a trial that we can throw lots of patients on. So we were having difficulty for various different reasons getting patients on that trial. So we're taking our poker chips and putting them in another trial. So that other trial, hopefully within the next few months, we'll have a replacement trial for that.
Not so much a question. I did IL-2 with Dr. Patnode in January 2010.
Wow.
And after my first round, I did the first round in and out.
Yep.
And I got rid of 90% of my spots on my 2 months.
Wow. So.
And I did the second round again in May. And I was supposed to do the third round in September. And I said, there's no use. I got a CAT scan again in October, or in September, October, and everything's gone. I still got 2 or 3 small spots in my lung, but there's just Dr. Cannell said they haven't changed the cellular shapes since I've diagnosed. So
Yes.
it was hard treatment, but what bothered me worse was the skin, the dryness of the skin,
Dryness of the skin.
itching.
Yeah.
And flu symptoms just when you're in the hospital, but
Yeah.
it's gone.
So just to let people online know what your story is, so there's someone in the room who took interleukin-2. So it's probably one of the hardest systemic therapies to take, but it's very short course. It's over,
Back to normal
yeah.
after 1 year. Now
Yeah.
I read it with people on the other drugs.
Yeah.
Year, I'm on nothing.
Yeah, so there are some great success stories.
I've been 3 years now.
Wow. And she, sorry.
9 months now, CAT scans.
Yeah, so the person in the crowd had 90% response rate and a durable response. That's the key with interleukin-2, that people who get it, who have a response, there's a small cohort, such as yourselves, that it just lasts for a long time. And so we love those success stories, and that's why we don't give up on that option. We always explore it. Our biggest obstacle to that option right now is the government and not funding it. So if you guys can step forward and say that you want to keep that open as an option for maybe not yourself, but the next person who comes along, that would be great if you write a letter to the government and say, we hear about this interleukin-2 and success stories that do happen. It should be an option to consider.
So would that be the province?
That would be the provincial government, yeah. Yep, another question?
Do you know if Dr. Patnode's at the hospital in Montreal accepts patients who have had a prior therapy?
So we do discuss with Dr. Patnode patients we want to consider. He's been reluctant to. So the question was, Dr. Patnode take patients for interleukin-2 who've had previous therapies? I don't think there's an absolute yes or no, but I can say he's been reluctant to treat someone who's. I didn't list all the side effects of sunitinib or pazopanib, but when you clamp down on blood vessels, the heart is a big muscle with a lot of little blood vessels in it, and so we always check someone's heart to make sure that they don't have, silent heart disease that wouldn't tolerate losing any little blood vessels. But even in someone's normal heart who takes these drugs, there is a little bit of probably damage done to the heart that in day-to-day life you wouldn't notice, but if you stress the person as stressed as you can get, which is interleukin-2 treatment, it may bring out the fact that there's been some heart damage done. So he's worried that the toxicity rate of the interleukin-2 will go up if you've had previous therapy. So he's been, as it stands right now, reluctant to treat patients who've had previous, but I don't think it's a black and white, cut and dried thing. And he would, but right now we're not referring any patients because the treatments are, $150,000 and there's no one to pay for it. So.
Well, I had to do the heart stress, the bone scan, and I had to do many tests before I successfully.
Correct. There's a whole workup. It's a more rigorous workup that you would have than you would have for going for a surgery. It's quite. He's got a list this long. He sends to us of tests we have to do before people would be considered. Is there any other questions? Oh, at the back, yeah.
You spoke about surgical intervention on the primary cancer.
Correct.
I just wondered for the metastases, is there any value in trying to remove like blood nodules or other stuff?
So, and Dr. Breaux can chime in here. So the question is would you ever do surgery on the metastases, not just the primary? There are very selected scenarios where we will consider taking out metastases, what we call oligometastases. If you have one, maybe two spots somewhere else, we would look at that scenario as a potential for cutting everything out. Generally, we want to know a little bit more about the cancer, how aggressive the cancer is, how long have those spots been there. We may do things like start systemic therapy for a period of time to ensure no other spots pop up, and then reassess the patient at a time. But in the vast majority of patients, we don't do that, but there are very selected cases where there might be one or two lung nodules or an isolated, maybe bony spot that we might consider just radiating very aggressively because, giving systemic therapy has lots of side effects. Even though it's a pill, sunitinib or pazopanib, they both have significant toxicity. So if we can get away or buy a period of, even if we're not going for cure, buy a period of time with no treatment, with some local treatments and then no treatment, we might consider that. So I hope that answers your question. Yeah.
The question on the webcast.
Oh, sure. Webcast question. How do you deal with the Ontario-Quebec border? Can a Gatineau patient get treated and be reimbursed for treatment in Ontario, vice versa? Unfortunately, the Ottawa Hospital treats patients from both sides of the border. If a patient gets admitted to hospital, we will see Quebec patients in the hospital and we will manage them. And I'm not sure about surgeries at the Ottawa Hospital. With respect to medical oncology and our systemic therapies, there is a new, very well-staffed, in fact, I've trained a couple of the oncologists who work over their clinic in the Gatineau side, that we would refer, we give it our opinion, but to receive their therapies, we would ask them to go back to the Gatineau side because of funding issues and a number of other things. But we collaborate, we talk back and forth. In fact, ironically, sometimes the Quebec side has better access to some drugs than the Ontario side, which a lot of people, we all have our pros and cons to our way our systems work, and the patients on the Quebec side sometimes have better access to certain drugs than on the Ontario side.
You also have a comment.
There's my daughter. Sorry, go ahead.
Most someone know the Quebec-Ontario border, I'm a Gatineau resident, and I have to go to Montreal.
Yeah, it's not ideal. Yeah, I mean, I guess, I'm not sure if you have to go to Montreal for every assessment.
No, not for everything.
Yeah, you go for your consultation and your recommendations for a treatment plan, and then Gatineau will manage that plan until there's a change necessary. And yeah, it's not ideal having to drive distances, but anyways, maybe someday the provincial borders will break down. Yeah.
The main reason for it, the surgery, is the Quebec government won't fund the hospital or the operation, and the Ontario government doesn't either. So, same thing for surgery. If a patient needs an emergent surgery, obviously they get treated. If they're an inpatient, that's not an issue. But the surgeons do it for free, and the hospitals don't get anything.
So Dr. Breaux is just explaining a follow-up on the Ontario, Quebec from a surgical standpoint, that emergency surgeries are done, they don't worry about the funding, but elective surgeries, the hospital can't afford to do those for free, so they'd be referred back to either Gatineau or Montreal. Another question?
Yeah, about METS surgeries, I've had some good results with radiation on the bone and bladder and cyberknife for the brain.
Yeah, no, we don't have a radiation colleague here with us tonight, but radiation is essentially surgery without the cut. And we're very lucky, you were just commenting that you've had the cyberknife in Ottawa, so the cyberknife allows very focused radiation to areas with minimal damage to the surrounding areas. And traditional radiation, I mean, it's all the same radiation, just the way it's given, works tremendously well in unique scenario, in different scenarios. So yeah, it's definitely part of the, you might read, radiation doesn't work in kidney cancer, that's a fallacy. It works very well in kidney cancer, but in selected scenarios. Is there any more questions for Dr. Bro? I'll let you guys. Okay, thank you.